Hello, my name is Dr. Philip Mease. I'm the Director of Rheumatology Research at Swedish Medical Center and Clinical Professor at the University of Washington School of Medicine in Seattle, Washington. This program is on the assessment and management principles for psoriatic arthritis. Psoriatic arthritis is a polygenic autoimmune disease characterized by arthritis, enthesitis, and spondylitis, as well as the skin disease of psoriasis. It occurs equally in males and females. Psoriasis occurs in 2 to 3% of the general population. Psoriatic arthritis occurs somewhere between 6 and 39% of psoriasis patients, depending upon the case series. The true prevalence probably lies in the 25 to 30% range of all patients with psoriasis. Various large telephone surveys of psoriasis patients done in the United States and in Europe have yielded the range of between 11 and 30%. The severity of psoriasis is not predictive of the severity of psoriatic arthritis, but is correlated with the occurrence of psoriatic arthritis. And we know that in the great majority of patients, psoriasis, skin disease, occurs long before the development of the arthritis symptoms, often as long as 10 years. A more recent finding is that obesity appears to be a risk factor for the development of psoriatic arthritis in patients that have existing psoriasis. So, potentially a modifiable risk factor. The next slide shows the interwoven relationship between a number of different diseases that fall within the spondyloarthritis spectrum and associated conditions of psoriasis, inflammatory bowel disease, and uveitis. Historically, the 5 subsets of spondyloarthritis include not only psoriatic arthritis, but also ankylosing spondylitis, the arthritis associated with ulcerative colitis or Crohn's disease, and reactive arthritis, which used to be known as Reiter's syndrome, and is related to some infectious antigenic stimulus of the immune system. For example, after developing Turista from Salmonella or Shigella, or Yersinia or Campylobacter would be examples. And then there's a category known as undifferentiated spondyloarthritis that has some clinical features characteristic of SPA, but does not fall into one of these other buckets. There are a number of features that tie the spondyloarthritis together clinically, and I'll be touching on those in the upcoming slides. This next slide is a bar graph showing the results of a number of studies that have looked at either populations or specific study cohorts to try to understand the prevalence of psoriatic arthritis within psoriasis patient populations. And as you can see, there's a wide range, but more recently, it's come closer to this 25 to 30% range that we are currently projecting. One point that's worth keeping in mind is that there may be what we call subclinical psoriatic arthritis. There could be a number of patients with psoriasis without musculoskeletal symptoms who have advanced imaging evidence of arthritis, for example, MRI abnormalities or ultrasound abnormalities that are consistent with an arthritis condition or enthesitis, which may either predate the ultimate appearance of psoriatic arthritis or represents a subclinical form of it. Let's talk about the classification criteria. The historical classification criteria was developed by Moll and Wright and published in 1973 in Seminars in Arthritis and Rheumatism. This was based on their evaluation of a large cohort of patients that they had collected in Leeds, England. And their definition of psoriatic arthritis was an inflammatory arthritis in a patient with psoriasis who had negative rheumatoid factor and one of 5 clinical subsets. oligoarticular disease, less than 5 in ball joints, that was asymmetric in character. Polyarticular disease, which was often more symmetric in nature and a little bit closer in appearance to what we think of as rheumatoid arthritis. Distal interphalangeal joint predominant disease. Spondylitis predominant, meaning primarily in the spine. And then a rare but very severe form called arthritis mutilans, in which the distal joints of the fingers and toes could be completely destroyed and adjacent bone dissolved. More recently, Philip Hellewell from Leeds and his then fellow at the time, Will Taylor, gathered a number of us together, 31 centers in all around the globe, to do a larger study based on patient evaluation in our centers. We enrolled about 1,000 patients in this study, half of whom we considered to have psoriatic arthritis and the other half to have an inflammatory disease that was not psoriatic arthritis, most of them having rheumatoid arthritis. After a very thorough evaluation of history and physical elements, the laboratory and imaging elements, and a lot of computer crunching, the classification criteria known as CASPAR was developed. The stem of this requires the clinician to make a judgment about the presence of inflammatory musculoskeletal disease involving the joints, spine, or enthesium. If that is present, then you can apply looking at the remainder elements that are listed in this slide. And if you get 3 or more points, then you can be classified with psoriatic arthritis. Current psoriasis is a powerful enough predictor that it is awarded 2 points, and all the other elements are awarded 1 point. Many patients come in to the classification criteria having current psoriasis and a negative test for rheumatoid factor. Having said that, though, I should mention that about 5% of the patients in this study had very clear-cut psoriatic arthritis, but also a positive rheumatoid factor, and slightly over 8% had a positive CCP antibody. So presence of these antibodies does not rule out psoriatic arthritis. Other features that were telling included nail changes, dactylitis, and one imaging finding, which was radiological evidence of juxta-articular new bone formation, osteitis, as we call it, that was typically periarticular. I'd now like to show you several images of characteristic clinical features of psoriatic arthritis. In this photograph sequence, we see patients with prominent DIP synovitis in the upper left, both PIP and DIP synovitis in the upper right. And in the lower images, we see evidence of dactylitis. For example, in the lower left, the patient's left fourth finger, and then in the lower right, the third toe. Swelling of the whole digit is due to synovitis plus tenosynovitis, and this is fairly unique to the spondyloarthropathies, and in particular to psoriatic arthritis. You also see in several of these images the characteristic nail changes of psoriasis, and there's a special relationship between the presence of nail disease and the presence of psoriatic arthritis, with nearly 85% of PSA patients reporting nail changes. The next slide shows evidence both of bone formation in the form of periostitis and ankylosis, but also at the opposite end of the spectrum, joint osteolysis, so both bone formation as well as striking erosions and osteolysis being possible, and sometimes in the same patient, although probably with different cytokines driving the process. In the next slide, we see some representation of enthesitis. First, a photograph of a patient with striking right Achilles tendon swelling and inflammation. Although usually it's not visible, it's mainly something the patient reports or that you palpate. And then the cartoon showing an inflammatory infiltrate at a tendon insertion into bone, and a photomicrograph from one of our patients showing a mononuclear cell infiltrate. Anywhere where a tendon, ligament, or joint capsule fiber inserts into bone, especially in sites of potential trauma or pressure, can lead to evidence of enthesitis ultimately in psoriatic arthritis patients, with insertion of the Achilles tendon and plantar fascia being prominent places where this can occur, but also around the kneecap, around the pelvis, around the rib cage, around the elbow, and so on. Cutaneous features are noted in the next slide. Here on the left, we see a classic psoriasis set of plaques, erythema, induration, and a silvery scale due to keratinocyte overproduction and prolonged survival. One thing to note about the psoriasis lesion is that when it clears, it completely clears without leaving scarring, whereas when joint inflammation occurs, the patient has joint damage that is permanent. Thus, the importance of jumping on psoriatic arthritis with appropriate management. The nail disease is shown to the right, which can range from simple pitting or mild changes to the severe changes you see here of onycholysis. Spine involvement is present in up to 40 or 50% of patients, and here is shown asymmetric sacroiliitis in the left image, and this patient's left SI joint is showing narrowing and erosive change with some periarticular sclerosis. And on the right, we see the syndesmophyte formation bridging vertebra. Also, uveitis may be reported by patients historically, and sometimes it's ophthalmologists who pick up the possible presence of psoriatic arthritis and triage the patients to rheumatologists for evaluation. Let's turn now to assessment of psoriatic arthritis as it's done in clinical trials and how we go about measuring the different clinical features that I've just spoken about. Here is a list of some of the measures that are done in clinical trials, and I want to emphasize the point that not only are we looking at arthritis and skin disease, but we're also trying to measure enthesitis, dactylitis, the spine, as well as the impact of inflammation and disease in all of these clinical domains on patient function and quality of life. So we tend to use the 68-66 joint count, 68 tender, 66 swollen, because of the tendency for joints in the lower extremity to be involved. And these then are used in the ACR, DAS, and so-called PSARC scoring systems, and there are new composite responder indices that are now in development that are more psoriatic arthritis specific. Axial assessment can be done with the ankylosing spondylitis measures as described here, the BOS-DI-BOS-V and BOS-ME, the latter being measures of the spine motion. Skin assessment, there are a variety of tools, PASI score, target lesion, position global, which are used in trials. Pain is measured on a VAS scale, as is patient global, and I should mention that when you're doing the patient global, it's important to ask not only how the joints are affecting the person, but also the skin, and same with the physician global. Various ways of looking at function and quality of life, including the HAQ scoring system, the SF-36, something known as the PSA-QOL, and the Dermatology Life Quality Index. Fatigue has been measured by a number of different measures as listed here. Enthesitis, there are a number of measures that have been developed, including one that is psoriatic arthritis specific from Leeds, in which 6 different enthesial sites at the elbow, the knee, and the Achilles tendon are measured. And then also one called the SPARC, or Canadian Scoring System, in which a total of 16 sites are scored, and the Maastricht, or MASIS, which has been developed in ankylosing spondylitis patients. Dactylitis assessment is usually assessed by the presence or absence of finding a swollen digit, but there are also more quantitative ways of measuring dactylitis, including the Leeds Dactylitis Index. Acute phase reactants such as severity and CRP are measured, and imaging using X-ray, using a modified Van der Heide Sharp score, and then advanced imaging with MRI or ultrasound to improve sensitivity for finding either erosive changes or inflammation at an enthesial attachment or bone edema. Here we see this striking change in joints that can occur when we're assessing for tenderness or swelling. Here in the next slide, I've shown various the points for the various enthesitis indices, and I would focus your attention on the red dots for the Leeds instrument at the elbow, knee, and Achilles tendon insertion, and the various sites of the spark. You don't need to remember these now, but just be aware that when you see these resulted in clinical trials, this is what we're looking at. Here is example of either counting or observing a foot for presence or absence of dactylitis, and using the Leeds dactylometer for measuring dactylitis. Skin disease, there are a number of measures, as I mentioned before, and I'm not going to go into them in detail now, but just be aware that we have quite quantitative ways of measuring skin disease, and it's changed with treatment. Nail disease, ranging from a simple visual analog scale to something more quantitative, such as the NAPSI score or modified NAPSI score. Now, as we go about our assessment, then we want to know how to put this into perspective as to whether the disease is mild, moderate, or severe. This next slide shows a grid in which that's the basis for a treatment recommendations article developed by the GRAPPA Group for Research and Assessment of Psoriasis and Psoriatic Arthritis. They emphasize the importance of assessing all the clinical domains of the disease: arthritis, skin disease, spinal disease, enthesitis, and dactylitis, and then show different levels, if you will, of what constitutes mild, moderate, or severe change in each of those clinical domains. For example, the number of joints involved, or in the case of the spine disease, the degree of pain or impact on function. I want to emphasize that in each of these gradations, we've taken into account not only the specific physical change, but also the impact on quality of life and function. Because if you, say, have a person with a bit of dactylitis or an amount of enthesitis, but if it hugely impacts their ability to work, then this should be taken into account, if you will, as a multiplier to make the disease more severe for considerations for therapeutic approach. There's also a target for treatment that has been developed by the GRAPPA Group known as minimal disease activity criteria. A patient is classified as being in MDA when 5 of the 7 elements following are met, including tender or swollen joint count less than or equal to 1, a very low skin score, patient pain VAS on a 100 scale being less than or equal to 15, patient global of activity VAS being less than or equal to 20, a low HAQ score, and a tender enthesial point score of less than or equal to 1. Now let's focus in the remaining time on psoriatic arthritis treatment. Here is a table developed again by the GRAPPA Group, who did a very extensive literature search leading to this set of publications in Journal of Rheumatology. And what you can see here is that, again, we've looked at the evidence for impact of different treatments on the different clinical domains of psoriatic arthritis, keeping in mind that we are focusing not just on treatment of joints or skin, but the whole disease. And as you can see, we have some evidence for simpler therapies like nonsteroidals or intra-articular steroids for treatment of the arthritis, and in the case of nonsteroidals, the spine. But we don't have good evidence for effect on dactylitis or enthesitis just because it hasn't been assessed, nor do we see impact of nonsteroidals on the skin. So as you can see, the best evidence we have for impact that's positive on the different clinical domains is with the anti-TNF medicines, and we don't yet have evidence for methotrexate or other oral DMARDs in dactylitis or enthesitis, and as you know, there's not significant benefit of these oral agents for the spine using the data from the ankylosing spondylitis trials as for evidence. We can use light disease, by the way, for treatment of skin. The traditional psoriatic arthritis therapies for the arthritis component are listed in the next slide, including NSAIDs and steroids. The disease-modifying drugs that have been used are listed here with a question mark after antimalarials because they are so-so in efficacy and have even been reported to have some flare of skin disease involved with them. Sulfasalazine has had trials showing some effectiveness, especially in the peripheral aspects of psoriatic arthritis. Leflunomide has as well. Cyclosporin can work for the skin, not so well for the joints. Methotrexate, interesting that this has tended to be used quite a lot for the treatment of psoriatic arthritis historically, but there's very little foundation for it in the form of controlled clinical trials. Here is a recent clinical trial, the so-called MIPA trial, or methotrexate in psoriatic arthritis trial, conducted primarily in England. This trial was very difficult to conduct. It took about 5 years to enroll the trial. Many of the patients that were entered into the trial were considered to be the milder patients at various investigative units since the biologics were available, and many of the patients wanted to move on to those. And at the end of the day, about a third of the patients dropped out in each arm, leaving fewer patients for evaluation. So with all of these issues plaguing the trial, it's perhaps not overly surprising that the results were muddy. And it turned out there was no difference between placebo and methotrexate used at 15 milligrams per week in terms of swollen or tender joint count, changes in acute phase reactants, and some of the composite measures such as ACR20. There was some statistically significant improvement, changes in patient and MD global and skin scores. So this leaves us with an uncertainty about the true benefit of methotrexate in psoriatic arthritis, but nonetheless, we have enough of our individual cases that do have some response that it does remain a drug that is commonly used. One point to make, though, is that in retrospective analyses, it does not appear to have had a ability to inhibit structural joint damage. Now, in contrast, I want to show you in the next, the so-called RESPOND trial. This was conducted primarily in Russia, and it was open label. It was comparing open label use of methotrexate to the combination of infliximab and methotrexate. And the reason I'm showing it here is just to show you that in this trial of relatively early disease patients, the average disease duration was about 3.5 years rather than the 8 to 9 years common in many psoriatic arthritis trials. We do see some benefit with ACR responses in the green bar columns, the methotrexate arms, that are reasonable, as well as some going into DAS remission defined by less than or equal to 2.6. Of course, the combination does much better with infliximab, but I show you this here just to show that at least there's a little bit of open label data with benefit from methotrexate. Now, the next slide is a busy one, and the main purpose in showing it is just to give you a feel for the characteristics of the patients entering into phase 2 and 3 trials in psoriatic arthritis with the different anti-TNF medicines and also ustekinumab. We see that the patients are typically middle-aged, equigender. The psoriatic arthritis duration is typically around 8 years. They tend to be a little bit on the heavy side, and with evidence of fairly active disease, and enthesitis occurring in anywhere from 38 up to 77% of patients, and dactylitis typically around 40 to 45% of patients. Now I've summarized in the next slide a lot of data from different trials of anti-TNF medicines, showing you both ACR composite scores, which try to get across joint responses, and the skin scores as reflected in the so-called psoriasis area and severity index score. As you can see, the anti-TNFs do very well, following the 60-40-20 rules that Ed Keystone has popularized about ACR response with the anti-TNFs. And this is no exception in psoriatic arthritis patients. And as you tend to follow these out into open label, the responses even climb from there up into the 60 up to even 70% range on ACR 20 response, and with 20 to 30% of patients achieving ACR 70 response. The PASI responses, PASI 75 response, is typically up in the 60% range with the monoclonal antibody molecules such as adalimumab, certolizumab, golimumab, or infliximab, slightly lower with the etanercept, although in one trial with the etanercept called the PRESTA trial, when you doubled the dose, you could actually achieve closer to what we have seen with the monoclonal antibodies. I've included the certolizumab data here. This was just recently presented at the EULAR meeting as a late breaker, and so this is new information. All of these other drugs are approved for psoriatic arthritis except for certolizumab, which is in the midst of being evaluated for approval by regulatory agencies in different parts of the world. In other outcomes, the anti-TNFs achieve good response with about 60 to 75% improvement noted in enthesitis, about 60% improvement in dactylitis, function improving statistically significantly as measured by the HAQ, all the various measures of quality of life showing significant improvement, fatigue showing significant improvement, and structural damage being inhibited. So these are consistent across the different anti-TNF medications. I bring up this one slide to speak about safety of the TNF inhibitors. This is a meta-analysis of controlled trials of adalimumab in various disease indications. And the main point of bringing it up is just to say that although we generally educate our patients with numbers related to the rheumatoid arthritis data, that in psoriasis and psoriatic arthritis, some of the side effects may actually be fewer in number and percentage. For example, if you look at the serious infection line, the rate of serious infections in the psoriatic arthritis patients is about half that of rheumatoid and much less yet in psoriasis patients. Now, keep in mind that if you look at the N involved, these are patients from clinical trials, and there were many fewer patients in the psoriasis and psoriatic arthritis trials than in rheumatoid arthritis. So we may be missing some of the side effect issues because of that. Also keep in mind that the RA patients have some reasons for having more serious infections, such as being on steroids, which is not as likely in psoriasis or psoriatic arthritis, having more concomitant disease-modifying drugs, maybe having more comorbidities, and so on. So there could be reasons for this as well. But I want to bring this up just to indicate that there may be some differences in the different disease states. I'd like to spend the last few minutes in speaking about other therapies that are being or will be assessed And I know that there will be another talk in this series speaking about therapies that are emerging in the future. And this talk, I'd like to just speak briefly about medicines that are currently available for other indications, such as abatacept for the treatment of rheumatoid arthritis or ustekinumab for the treatment of psoriasis, but have some data in psoriatic arthritis. Whereas these drugs are both in a pathway to see if they can be approved in treatment of psoriatic arthritis, they are not yet approved for psoriatic arthritis per se. But I want to show you some of the data from the early psoriatic arthritis trials with these agents. Also, I'll mention while speaking on this slide is that anakinra, an IL-1 inhibitor, was carefully studied in a study in Dublin, and it was shown not to be effective compared to placebo. And I'll leave for the other talk some of the newer cytokine targets such as IL-17, IL-6, and the new oral small molecules such as the JAK inhibitors and phosphodiesterase 4 inhibitor. So, first of all, what does abatacept do? It is a co-stimulatory blockade agent that blocks the second signal of T-cell activation. In this case, abatacept inhibits the B7 CD28 interaction, and thus reducing T-cell activation. Here we have data from a phase 2 trial of this drug in psoriatic arthritis, and you can see if we focus on the 10 milligram per kilogram or the orange bars that you see response in the high 40% range in terms of ACR20 response, which is probably 10 percentage points less than what we typically see with an anti-TNF agent. Interestingly, in the next slide, if you break this out into the patients in the trial that had either seen anti-TNF therapy previously or not, we find that the patients who had not seen previous anti-TNF therapy had a much greater response, more like what we've seen with the anti-TNF medications. So it seems that there's something about prior exposure that is perhaps culling out a patient group that is more resistant to treatment that may have blunted some of the overall results that we're seeing in the when you combine these groups together. This drug is being studied in its subcutaneous form. This was the IV form in this study, but in its sub-Q form in phase 3, and so it'll be exciting to see what we learn from that. I should mention that the results in this, again, were not as effective as what we've seen with the anti-TNFs. And that's shown here, the PASI 50 response. Again, if we follow the orange bar along, this is in the 40% range, and this is PASI 50, not PASI 75. So a possible option for your patient that, say, for example, can't take an anti-TNF medicine for one reason or another if used off-label, and we are in the midst of developing it for potential labeling for approval. I also show some MRI scores here that show impact on erosion and osteitis, so a sort of a biological proof of concept. Now I'd like to just, and at the very end, speak to T-cell differentiation pathways and IL-17 TH17 pathway inhibition. And there's a drug known as ustekinumab that blocks IL-12 and IL-23, so potentially blocking both Th1 pathway mode of inflammation and Th17 pathway mode of inflammation. Here, the ustekinumab molecule blocks the P40 subunit that is common to the IL-12 and IL-23 receptor on T-cell surfaces. Here we see phase 3 data in a psoriatic arthritis trial with 49.5% achieving ACR20 in the 90 milligrams sub-Q Q3 months arm with ustekinumab, And then you see also the ACR 50 and 70 responses there. Slightly lower responses in the 45 milligram group. In the skin, we see very good PASI 75 responders, and we know that this drug works well in psoriasis and for which has been approved. This drug also showed improvement in dactylitis and enthesitis, and it is now pending evaluation by the regulatory agencies for possible approval in psoriatic arthritis, and again, a potential alternative to anti-TNF treatment for patients. There are a number of other drugs in the pathway of development that you'll be hearing about in a different lecture, and the questions that we'll be asking of all these drugs is comparing them to the results that we've seen with the anti-TNFs, which work well but don't work in all patients and may lose effect over time or cause side effects, and so thus new drugs are needed. And the questions we'll ask of them: where will they fit into the armamentarium of care? Will they impact all clinical domains of the disease, as I've been emphasizing throughout this lecture? Will they prevent structural damage from occurring? Will they benefit cardiovascular outcomes, as has been shown but not spoken about during this talk with the anti-TNF medicines in rheumatoid arthritis, and we would potentially hope with psoriatic arthritis? And will there be any new safety issues that need to be focused on? And what implications will there be in comparing the parenterally administered medicines, either sub-Q or infused, versus oral treatments? And then, of course, what will their costs be and their practicality in the world at large? So with that, I'd like to close and thank you for listening to this discussion about assessment and treatment of psoriatic arthritis.